the modern face is a smaller face, right? It's a face that, because of whatever reason, is not as projected as it used to be. Well, if that's the case, and then you gather 100 or 200 people and you do a cephalometric analysis and you take a normal of the population, now your normal is a small face, right?
Right.
So then what are you doing? Every patient you're treating shy of their best, whatever is best for that individual. So you have to be careful. Again, I respect all the research that's been done through the years. You have to. It's like I said, you stand on the shoulders of others, but there's more to it, and getting a good result is about making the face work.
Mm-hmm. So you have, let's say, the Steiner analysis and surgeons that use that. You have the Arnett analysis, and then you have the modified Arnett analysis that considers function and perhaps airway. Maybe not airway. I don't know. You can comment on that. But how much difference are we really talking here? Are we talking a few degrees either way, a few millimeters either way? I mean, there's limits that the material structure in front of you imposes on the surgery too. So when all is said and done, how much are all of these approaches within like 15% of each other? How much difference are we talking? And then how much difference does a 20% difference in how people do things, how much does that affect a really beautiful, like, wow factor face in a before and after versus, that looks unnatural? Is this a game of fractions of a millimeter? What are we talking about here?
I mean, it can be. It just depends what the problem is. And so when I talk about function, it's really separate from the quote Arnett analysis or the cephalometric. When I'm talking about function, for example, I'm talking about being able to get your lips together. So I think we can all agree that the lips need to be together. Science has proven as much, that we're obligate nasal breathers as human beings, and which means that our brains are hardwired to breathe through our noses. And when we don't breathe through our noses, not only is it inappropriate to the physiology, but mentally it's disconcerting and disturbing for people. That's why, so take it from a standpoint of social norms. That's why we have pejorative terms like, hey, mouth breather, there's this underlying like recognition in our souls that people that mouth breathe are not healthy, that something's wrong and they're not part of the pack. And that's a problem, right? So having the lips touch, that's not part of any analysis. That's a functional decision, right? Well, how close do the lips have to be together in order for it to not be dysfunctional? So, I mean, that's really your question. It's like, is it a question of millimeters or fractions of a millimeter? And the answer is, well, it just depends on the size and shape of the lips. So when you have a patient that you're looking at for surgery, let's use, for example, the Steiner analysis to position the parts. But because Steiner doesn't take into consideration the lips being apart, let's just do the surgery with Steiner. Well, that's fine. You're going to get fairly close to an aesthetic result. Maybe not, definitely not as good as the Arnett analysis, which would help you understand occlusal plane and the projections of the face. Okay, great. So let's use the Arnett analysis then on this patient. Well, we're going to get a better result. The balance is going to be better between the nose and the chin because we are now measuring the face. But if we still disregard the lips and we leave them apart, say 2 or 3 millimeters, is that going to make a difference? Well, it depends what you're dealing with the patient. If on the backside of the surgery, you have the parts in the right place, but then the patient has to do this all day to put their lips together, is that aesthetic? No, it doesn't look good.
No.
So your parts might be in the right place according to some analysis. But if they're not functioning well together, then the face doesn't look right. And it is a final outcome. Will the patient, this is a great question too. It's like, which is kind of where I think your podcast comes from. It's like, how do lay people understand jaw surgery? And what's phenomenal is that there are people who can get a big change in their jaw positions, and they are ecstatic with the outcome. They love it. But because they lived most of their lives with their lips apart, and the lips are still apart post-surgery, they don't know. It's like they don't know any different. Nobody told them that it was possible to have the lips touch when they're done. So they're cool with it, right? Because they don't know. But if you actually told the patient after the surgery and said, you know how your lips don't really come together? Well, yeah, that's I have to work at it. Well, what would it be like if you didn't have to do that? Well, that would be great. Oh, okay. Well, let's provide that for you. Let's give you that relief. And then for some patients, the disability of having your lips apart is enormous. Posture problems, neck problems, jaw problems, migraines. And then, of course, the mouth breathing at night, which leads to sleep disorder breathing and things like that. So it can be quite dramatic. So is it a case of millimeters? Yes, in some cases it is. In others, it's more than that, And then, again, as a conclusion, does the patient know the difference? And I would venture to say no. I mean, the individual patient only knows what they're getting. They only know the consultation they're getting. They only know the surgical outcome that they're getting. And in comparison, large discrepancies are going to be visible, right? I mean, those are going to be the obvious ones. But in the end, when you talk about these minor things, then maybe not so much. But is it worth it? Yeah. I mean, it's worth it. It's where I grew up. Grew up. In residency. I grew up in residency. I learned how to do surgery in residency. And there were some attendings in residency that were like, well, if you're not going to do a 6 millimeter genioplasty, what's the point of doing it? Well, I find there's a point in doing a 2 millimeter genioplasty for sure. If I can get the lips to touch, or I can get a balance out of 2 millimeters or even a millimeter, I'm going to do it. Because why? The surgery itself is so inaccurate and complicated in general. Why should we cut ourselves short of trying to achieve a functional and aesthetic perfection, which we'll never achieve? But why cut corners if the surgery itself is going to make it difficult anyway?